Okay, let's begin with an overview of the opt-out model for tobacco cessation. My name is Derek Noland. I'm a community liaison here at the Behavioral Health and Wellness Program at the University of Colorado School of Medicine, and I do manage the Tobacco Innovative Grant Project. So here are the training objectives for today's webinar. This forward-looking webinar is designed to define and describe the opt-out model for tobacco cessation while considering how it differs from the status quo in tobacco dependence treatment. I'll be providing the rationale for utilizing the opt-out model for treating tobacco dependence as well. And finally, we'll examine the benefits and the ethical imperatives that recommend implementation of the opt-out model really across all different types of healthcare settings. This webinar, again, is part of a three-part series, this spring being offered via the Tobacco Innovative Grant Project. The TIG project is funded by the State Tobacco Education and Prevention Partnership Program at the Colorado Department of Public Health and Environment, or CDPHE. This project is designed to provide training and technical assistance to organizations across Colorado that might be interested in implementing and or expanding other nicotine policies and tobacco treatment services. Later this spring, BHWP will be releasing the Behavioral Health Cessation Coordination Model Toolkit. We previously released the BHCCM itself last year, but the toolkit will provide organizations with a blueprint for how to utilize the model and how to evaluate the tobacco treatment services they offer. Looking forward, BHWP will be continuing to create new toolkits in years to come, with a tobacco-free toolkit for healthcare providers on the docket for next year, which will include an addendum focused on behavioral health populations. And it's worth noting all of these materials are uploaded to the BHWP website, bhwellness.org, and they're available for free public download. There's currently openings in the cohort for next year's TIG project, so if your organization is interested in participating, please let me know to get more information. Okay, and so in addition to this webinar, we'll be having two more this spring, still determining the best topic for the one in May. However, at the end of June, we'll actually be introducing the Behavioral Health Cessation Coordination Model Toolkit itself, which I just described. That will be completed at that time. Okay, let's turn our attention now to the opt-out model for tobacco cessation. In beginning this webinar overviewing that model, it's important to start by defining and describing what it is we are talking about, and of course, how this model differs from the current status quo in tobacco dependence treatment, which has unfortunately been the opt-in model for far too long now. While research into the effectiveness and the cost basis for the opt-out model is ongoing, as we shall see, the new approach is steadily revealing itself to be a superior option for routing clients to tobacco treatment services, and shows great promise from a cost-effectiveness standpoint, especially when considering the long-term costs of disease caused by tobacco use. And while I say the opt-out model in this context may be a new approach, it is by and large not a new approach in most healthcare services. Okay, so before highlighting and focusing on the opt-out model, let's begin by reviewing what has been the standard of care in tobacco treatment services for many decades now, which we will call the opt-out, opt-in model for the purposes of this webinar. The key distinguishing feature of the opt-in model is that it requires the client to actively decide to opt in to receiving tobacco treatment services. In a typical workflow, a client presents for care, whether traditional medical care, behavioral health care, or any other type of care, and is, ideally we hope anyway, screened for nicotine and or tobacco use. As a brief aside, I may go back and forth between the terms nicotine and tobacco, and we'll mostly use the term tobacco out of convention and habit. However, do note that nicotine is the better coverall term, as it includes electronic products that provide the user with nicotine, even when tobacco itself is not necessarily present. So after the screening process has occurred, people who report nicotine use are offered treatment services. Again, this is the ideal case, though this does not always occur in practice. The way in which the services are offered may vary, but ultimately the client has to choose to accept treatment in an active manner. If they do nothing, they will not receive treatment. And as a result, it is much easier for the client not to do anything and therefore not receive treatment. Of course, this approach is different from treatment modalities for virtually every other type of disease. For example, if a person is diagnosed with diabetes, they automatically begin to receive support in managing the disease, such as consultation, advice on monitoring blood glucose levels, potential behavioral modifications, and so forth. Even in cases of a substance use disorder, this is the general approach where the person is automatically routed into treatment. However, this is not the case in most settings when someone is diagnosed with tobacco dependence, and certainly has not been the case historically. The opt-out model for tobacco cessation, on the other hand, simply corrects this less than desirable approach to treatment by treating tobacco dependence in the same way as we would any other type of disease. Too often we see that tobacco use is treated in a silo, and that it is treated differently from other conditions, often treated individually outside of other care, and often outside of treatment for other types of conditions as well. Thus, the opt-out model is another step toward eliminating this faulty approach to treatment. To continue with the model, the same approach as with the opt-in model is followed initially. All clients are screened for nicotine or tobacco use. However, when someone confirms that they are using tobacco, they are automatically referred to tobacco treatment services, whether internally or even externally or outside of the organization if necessary. In such a scenario, the client must now actively decline or opt out of the referral for treatment. They have to go against the advice or the standard procedure of operation of that provider and decline the coverage, which will lead many clients to simply pursue the treatment option instead. So we're taking advantage of whatever motivation may exist in the client. And as we know, motivation for tobacco cessation tends to come and go. We may be able to capture that motivation in the moment. Thus, the opt-out model is setting a standard that all clients who use tobacco will automatically receive treatment services and sets this methodology as the new default approach. And as a result of this, it's much easier for the client not to do anything and therefore not receive treatment in that opt-in model. Okay, here's a head-to-head comparison of the two models that I've just described, with the opt-in model on the left and the opt-out model on the right. Again, you can see that they both begin with tobacco use screening at intake, and note this should occur at every patient encounter as a best practice. But when a positive assessment is made, the models change direction. In the opt-out model, the client must decline to accept the recommended service. And as you can see at the bottom of the boxes, the model on the left has been the typical standard for many decades when it comes to tobacco dependence, and essentially only for tobacco dependence, as we have seen. The opt-out model simply falls in line with the manner in which healthcare services are typically offered for essentially every other type of health concern. Here's another head-to-head example of the two models, this time dealing the way in which an electronic health record, or EHR, can be rendered to support either of these types of models. The two sample prompts provided here are very different. In the opt-in model, the prompt reads, "Quitting tobacco is the most important thing you can do to improve your health. Would you like to discuss treatment options?" As you can see, this is a very passive approach and allows for an easy no response from the patient. And yet this is a good example of the type of prompt that we do typically see in EHR systems. This would be read by the professional who's working with the client, hopefully in a vigorous and informed manner, but sometimes read even in a very passive manner as well. So on the other hand, the opt-out model prompt on the right there is much more rigorous. To read that prompt, the EHR would prompt the provider to say, "All of our patients who use tobacco are referred to a specialist to discuss counseling and medication treatment options." So here the treatment is presented as a default operation. An assumption is made that the client will pursue treatment, and the client would have to actively decline the referral. That referral might be to a tobacco treatment specialist, for example. It could even be an external referral if for some reason this organization does not offer tobacco dependence treatment. Whatever the case, we are assuming that the client will pursue that referral. So these types of prompts in electronic health records can be very helpful in routing people to treatment services and in helping to assure that they are actually offered to individuals. Of course, there are other ways in which the referral can happen outside of an EHR structure, for instance, simply by the provider's direct recommendation. Another consideration when implementing the opt-out model is that it can be done across a spectrum of different intensities based on the practices of the provider and the healthcare organization. In a low intensity opt-out approach, as we can see on the top left there, treatment is still assumed, but the client might only be provided with general information about the tobacco cessation options and the services available to them at that organization, such again as counseling and medication. Moving up to a medium intensity approach in the middle box, again, treatment is still assumed. And in this case, the available treatment services are more actively discussed with the client during that encounter. However, arguably the best version of the opt-out model and the one receiving a lot of and the most really traction and attention is the high intensity approach, as you can see in the bottom right there. In this approach, treatment is not only assumed, but the client is automatically enrolled in treatment services. For instance, they might have an appointment scheduled with a tobacco treatment specialist automatically, or they might be referred to a prescriber or a pharmacist to receive cessation medication. They might even have some sort of automatic referral externally outside of the organization, again, if it's one that does not offer these services directly. Whatever the case, this very big next step is performed again automatically, and unless the client declines and opts out of the service, the client begins receiving treatment as a matter of standard practice. Most research into the opt-out model operates at the high intensity level, which in all likelihood is the ideal approach. And we'll be looking at some research into the opt-out model a little bit later in this webinar. One other way to consider the opt-out model is to think about the different times at which it can be utilized, alongside different strategies for implementing the model. Thus far, we've primarily focused on the first of these three strategies that you can see listed here in blue, in which a client is physically present at an appointment and is referred to treatment services during that appointment. This approach is most often what we are talking about with the opt-out model, but it's worth again noting that these other approaches that you can see here in blue are valid too. For an example, an organization could plan to perform routine outreach to clients who've previously screened positive for tobacco use, but have not yet initiated treatment for whatever reason. The organization could have dedicated staff call the clients or send them emails with the assumption that the client will then follow through with treatment services. So again, in this setting, we'd be utilizing an opt-out approach where the client would have to decline the services. The call would be to set them up with those services and would assume that they would be doing so. Similarly, an organization could plan to send out bulk communication to all of its tobacco-using clients, say quarterly as an example, perhaps by email, even physical mail, a direct phone call, or an automated dialer. Again, assuming they will proceed to treatment services upon receiving that message. Again, it's worth noting that these approaches need not stand alone. Rather, they can all be used at the same time by the organization at whatever frequency is feasible from a capacity standpoint. So of course, we could be doing the in-person referrals, and we could, on top of that, have periodic outreach via phone, and also the perhaps quarterly bulk communication as an example. These could all be happening at the same time. Okay, so we've now established the characteristics of the opt-out model for tobacco cessation and how it differs from the standard opt-in model that is most commonly used in treating tobacco dependence. But why is making this seemingly subtle change so important? Well, before we examine some of the direct benefits of implementing the opt-out model, it's important to spend some time to understand that it is primarily the overwhelming burden of tobacco upon the US population that really drives the need for improvements in this field. Simply put, we need to limit the damage that tobacco is doing to our society. And that is because, again, tobacco use is far and away the leading cause of preventable disease, disability, and death in this country. As you can see, every year we have nearly 500,000 tobacco-related deaths in the US. that number only increases over time as we learn more and more about how tobacco does cause disease, and as we're able to associate or causally link more diseases with tobacco. You can see worldwide, of course, this is a big problem with 8 million tobacco-related deaths occurring each year on the global scale. So naturally, the opt-out model is appropriate in other countries as well, and is utilized in many other countries. Not only are many people dying of tobacco in the United States and internationally, but 16 million people in this country are living with a tobacco-related chronic illness. An illness that can be very serious, that can undermine their health, their quality of life, their ability to achieve their fullest potential. Also, of course, a burden on the United States healthcare system, something that we need to consider when we think about the cost effectiveness of, in this case, implementing an opt-out model. Even if an opt-out model might be more expensive at startup than perhaps the opt-in model, simply because we might be treating less people, the long-term impact, perhaps both on that organization and on healthcare in general, can be much, much greater when we're talking about treatment, perhaps long-term treatment for very serious chronic illnesses. It's also worth noting that we do see about 41,000 deaths annually in the US simply due to secondhand smoke exposure. So this is yet another reason that we need to get people to treatment for tobacco use so that people aren't being exposed in that manner. Among other things, this slide shows why behavioral health care settings are ideal for implementing the opt-out model. The TIG project does work in behavioral health care settings, and really this diagram here is pointing out why that's so important. You can see of the 480,000 causes of death in the US, that approximately 200,000 of those are represented by people with behavioral health conditions. So to be clear, I'm talking about people who may have some sort of mental illness and or a substance use condition. So a relatively smaller proportion of the US population is making up roughly 40% of the burn of tobacco, of the cigarette smoked, of the tobacco market. So again, that's the primary reason why we do focus on that setting, why we want to make sure that the opt-out model is utilized in that setting too. You can see by comparison on the right that the behavioral causes of death related to tobacco are significantly higher than all these other types of conditions added together. So yes, this evidence points to, again, that tobacco impacts our society at such a high level. You can note here that tobacco is related to all of the top 5 leading causes of death in the US, as you can see here. So heart disease, cancer, accidents, cerebrovascular disease, and chronic respiratory disease. You can see that for 4 of the 5, they are direct tobacco-related illnesses where these diseases are caused by tobacco. Accidents, we point out that tobacco use is a risk factor here where people may be having fire related to cigarette smoking, oxygen tanks exploding, car crashes from distraction, simply being weakened by tobacco use and having an accident due to that. So a lot of ways in which that can play out. It's also worth remembering as we're looking at some of these conditions, such as cancer, say, or heart disease, that when someone is diagnosed with cancer or heart disease, they would automatically be routed to treatment for that. Again, using an opt-out model, which we see across really all different types of healthcare conditions. Of course, as we know, this is not currently the standard in tobacco use, and I think that this slide does a nice job of highlighting that discrepancy. It's also important to remember why we are helping people to quit, even beyond preventing death and disease. So there's a lot of reasons why we want to help people quit. As I've mentioned, it does improve their health and the overall quality of life. Alongside that, we see a decrease in symptoms of depression and anxiety, so better mental health, increases their healthy years of life, so not just living longer, but living healthier. Helping people quit improves the effect of medications for mental health problems and other types of diseases. Unfortunately, the presence of nicotine does speed up the metabolism of many other types of medications, causing people to have to take higher doses of such medications. And often these types of medications come with very significant side effects. Of course, they come with costs, both to the individual and the healthcare system and insurance providers. So another big factor there. We can help decrease people's social isolation if they're able to quit using tobacco. Obviously, they can save a lot of money simply by not buying cigarettes or electronic products. And at BHWP, we strongly believe that quitting smoking is a right. It's important for a person's recovery from behavioral health conditions, as well as recovery from injuries and surgical procedures and other sorts of medical conditions like that. And so here are some statistics from the 2020 report of the Surgeon General that looked at smoking cessation primarily. The fact is that most adults who smoke want to quit. It's another interesting consideration to make in regards to the opt-out model. Because we know that about 70% of adult smokers want to quit, it is logical to deduce that utilizing an opt-out model will help many of these people to quit successfully by helping to give them the nudge that they need to get started. As you can see, also every year, over half of all adults who smoke try to quit. However, not all quit attempts are created equal. Often quit attempts would utilize a cold turkey approach where the individual just tries to stop smoking abruptly. These may be kind of unplanned quit attempts, often done alone or in isolation, lacking support, obviously in that setting, perhaps lacking any sort of counseling, lacking medication, so lacking a lot of the benefits that they would receive from getting more proper tobacco dependence treatment, which would increase their chances of successfully quitting, as we will see. Now, with the opt-out model in place, we can help to make sure that these quit attempts are, again, supported with evidence-based techniques, such as utilizing those best practice counseling methods and FDA-approved cessation medications. And this is a very important factor. As we know, evidence-based treatments techniques are more effective, and yet, unfortunately, they are vastly underutilized in this country. The majority of smokers do utilize that type of unplanned cold turkey approach that I discussed. And so while the reality is more people do quit using that approach, and so it may seem that most people are doing that, the percentage of people who quit successfully doing that is much, much lower. It's simply the sheer volume of people who are taking this unplanned, unsupported approach. Thus, the opt-out model has the power to turn a passive, unplanned quit attempt into a much more robust quit attempt, one which will have a much better chance of succeeding. It's also worth remembering that people can and do quit. As you can see, 3 out of every 5 adults who have ever smoked have been able to successfully quit. So if we're supporting these people via the opt-out model, and thereby better treatment services, we can really make a profound difference here. To return our focus for a moment to behavioral health populations, there's also great evidence that they want to quit and are able to quit tobacco too, something that's often misunderstood by healthcare providers. We see that people with behavioral health conditions are in fact able to quit using. 3 out of 4 want to quit using, and perhaps even more telling, about 2/3 of people with behavioral health conditions try to quit in any given year. So this is another reason why it is absolutely imperative to utilize the opt-out model within behavioral health settings, as well as in traditional healthcare settings. So finally, let's look at the figures that back up what I'm saying. These are cessation rates based on the quit approach. These abstinence rates would be at 6 months post-quit attempt. So after the person stopped smoking, 6 months out, this is where their abstinence rate would fall. You can see the unaided or the cold turkey approach, kind of the off-the-cuff abstinence rate is the lowest, roughly at about 5%. So a very small proportion succeed this way. A self-help attempt in which the person is being more thoughtful and planning out their quit attempt, perhaps utilizing their own supports and different strategies, gets a higher rate, 11 to 14%. A quit line similarly get a better abstinence rate than cold turkey. And then when we start to move into individual and group counseling, we see another bump in the successful abstinence rates. Finally, looking at medication, we get a higher abstinence rate there too. And then medication and counseling combined really are best practice, our gold standard. We can see up to 30% abstinence rate often. So the opt-out approach is, again, to summarize, much more likely to route people to that gold standard on this slide, the medication plus counseling approach. And so people will just be a lot more likely to receive that combination treatment when they're automatically referred to tobacco treatment services, again, via the opt-out model. The primary benefit of implementing the opt-out model is the ripple effect that it creates in getting more and more people to evidence-based tobacco treatment services in order to reduce the burden of tobacco in our country. However, there are other real, meaningful benefits to consider, including enabling healthcare providers to perform their tasks more effectively, faithfully, and ethically. Again, the biggest value of the opt-out model is that it results in more people receiving tobacco treatment services and thus produces more quit attempts, better quit attempts, more successful quit attempts, and less tobacco-related disease, disability, and death. However, the opt-out model also helps organizations to standardize their services in order to make them operate more efficiently and effectively. Standardization also helps to limit the potential negative impact of both explicit and implicit biases that may be held by healthcare providers, as we will see in a moment. The standardization approach also assures that care is offered more equitably to all clients in a manner consistent with an ethically responsible approach to healthcare provision. In fact, on that note, simply offering tobacco dependence treatment services to all clients who use tobacco is an ethical imperative in offering healthcare. To not offer cessation services is denying people the ability to get support in quitting tobacco, which again is the number one thing most people can do to improve their health. Another nice feature of the opt-out model is that it can be implemented in a variety of different types of settings, in addition to the different types of approaches that we've already reviewed. Let's now look at the impact of each of these benefits in some more detail. So when we standardize services, we accomplish several key objectives. Firstly, we assure that we are offering our services to all of our clients as a matter of standard routine. With true standardization, people are not slipping through the cracks. Importantly, this approach also helps to address health disparities and the potentially negative impacts of the social determinants of health, a set of factors that make a person more or less disposed to better healthcare treatment and better health outcomes. Standardization helps to level the playing field so that all people have the ability to benefit regardless of their background and details of their lives. This approach ensures that organizations are therefore able to commit to the standard of treating all patients equally. Standardization also helps to reduce potential administrative errors or simply forgetting to accomplish a task. Healthcare providers have a lot on their plates and could easily forget to ask about tobacco use or to refer clients to tobacco treatment. Similarly, healthcare providers might feel a need to decide whether or not a client should be referred to a cessation treatment. And this is a slippery slope which can make the confounding presence of stigma and biases more likely. Additionally, a standardized opt-out model assures that all clients have the ability to access cessation treatment at every encounter. This approach therefore maximizes the limited number of client contacts that occur over any patient's lifespan. Motivation to quit smoking, as we've discussed, is fleeting. It can come and go regularly. And so if we're constantly referring to services, we're more likely to reach people at times when their motivation is high, therefore leading to better outcomes. So with limited client interactions, it's important to maximize each one. Standardization can help to directly lead to the mitigation of biases too, predominantly by removing them from the equation. If the healthcare provider does not make a decision about whether or not to refer a client to cessation services, for instance, these biases are less likely to play a role. Let's distinguish between the two key types of biases. You can see that explicit bias refers to our conscious attitudes and beliefs about a person or group. So these are beliefs that we know that we hold, that we're aware of. However, implicit bias, these are our unconscious attitudes or stereotypes that are activated involuntarily without awareness or our intentional control. And both of these biases can be limited through standardization. Implicit biases in particular are hard to root out without that type of structure, since, again, we do not always know that they exist. Implicit biases may exist related to a number of factors and can impact whether or not a person receives tobacco treatment services. For example, we have some listed here. A patient's health might lead a provider not to recommend healthcare services. Perhaps they're ill due to a long-time smoking habit, and the person thinks that they would not be appropriate for treatment. The person's age could be another example. If we're talking about an older adult who's a long-time smoker, the healthcare provider might implicitly assume that they're not interested, and that very well may not be the case. A lot of older adults are very motivated by the presence of chronic diseases, for example. Person's education, if perhaps of a lower educational background, the statistics show that these individuals do smoke at higher rates, and so the provider might subconsciously assume they're not interested. A health insurance coverage could be another factor where perhaps if they assume the client doesn't have good coverage, they might not be interested in the service. Importantly, the opt-out model can be used in both outpatient and inpatient settings. In an inpatient setting, it can be as a part of their standard of care. In some cases, it could even be a requirement of their care. At the outpatient level, we can offer, again, tobacco treatment services at every patient encounter, and we can schedule treatment automatically using the opt-out model. Behavioral healthcare settings are ideal for the opt-out model as well. As we have seen, this population does bear the heaviest burden of tobacco use, and yet also, as we have seen, they generally do want to quit smoking. Even substance use treatment generally utilizes the opt-out model. So the image here is from the behavioral health cessation coordination model. And here is that model in a little more detail. Note the different categories of services on the right, and also note the fact that the opt-out model can be utilized across all of these different types of services. Again, we hope that the soon-to-be-released behavioral health cessation coordination model toolkit coming out in just a couple of months, in which a webinar will be covered in June. This will help to shed more light on the categories here and how to offer tobacco treatment services across all of them. We hope that this model will help agencies or organizations to self-evaluate the care that they're offering and consider other avenues to offering services. Let's look at these categories in a little bit more detail on the next slide here. You can see our category 0 services are really our kind of overarching entry level, really not a service provision, more about health promotion, community-based prevention, early identification and intervention. So a different type of category, but one that was worth including in the model. Category 1 services, so mobile crisis response, there's some examples there you can see, such as co-responder services. This could be an opportunity for the opt-out model, where we assume that if an individual is using tobacco, that we set them up with services. Similarly, category 2, an on-site crisis service where the person may come in, perhaps for detoxification services. This is a good opportunity to screen them for tobacco use, and opt-out model, again, route them to services. Similarly, category 3 are outpatient or ambulatory services, and category 4, inpatient care, residential care. These are a lot of the type of settings that we've been discussing in this webinar, where people are more perhaps heavily involved in healthcare services, and clearly the opt-out model can work here and help them get to automatic services. All right, the publication pictured here on the right is really fundamental to the world of tobacco cessation. It's Treating Tobacco Use and Dependence. It's the 2008 update clinical practice guideline, and it remains really the standard in tobacco treatment to this day. The clinical guidelines point to the body of evidence that exists behind cessation services, so facts and effective treatments and techniques that have been evaluated over a long period of time and shown to have positive results. And we'll see some of these on the next few slides. So these guidelines really provide a blueprint for treating tobacco dependence. And in the opt-out model, we can route more people to these validated appropriate techniques. So first and foremost, the clinical guidelines do point out that tobacco dependence is a chronic disease that often requires repeated interventions. So a chronic disease, much in the way that some of the other types of diseases that we would treat with a standard opt-out model would follow as well. So this reality supports the use of routinely screening for nicotine or tobacco use, and then utilizing the opt-out model for referring clients to treatment services. And here are some of the key cessation strategies that we know the evidence bears out that these work. They help people to quit tobacco. And these are all treatment modalities for which the opt-out model, again, can help people to make connections. So we know that individual, group, and telephonic counseling are effective techniques. Each of those work, and that their effectiveness, moreover, increases with intensity. We know that both counseling and medication are effective in treating tobacco dependence, as we saw on our slide a few slides ago. Combining those really works best of all, and we get the best results. We do know that treatment is effective across all different types of populations. We've reviewed how behavioral health clients in particular are of interest and can benefit from this as well, but many other types of populations can benefit too. And another thing that the evidence-based guidelines have found is that motivational treatments may be effective even for people who are not yet ready to quit. So again, with the opt-out model, we're able to take advantage of what we know in this respect and able to get people to the best types of treatment. The 5 A's is a good structure for identifying tobacco users. So the 5 A's is a common model. You can see in the diagram there that tobacco dependence, again, is a chronic relapsing condition. And so repeated interventions and a systematic approach is the best way to first identify tobacco users and then to route them to care. So just to briefly cover this, we would ask all clients or patients who present whether or not they use tobacco. If they do, very important step, we would advise them to quit. We would advise them to quit in a non-judgmental, professional, and hopefully personalized manner. So a really heartfelt, significant advisement to quit. The third step would be to assess the level of dependence, perhaps. And so traditionally, often we're looking at their readiness to quit, but as we'll see, that's not really a best practice. We really want to assess their dependence. We assist them with getting support and next steps, and we arrange for follow-up, or we arrange, hopefully with the opt-out model, to referral to treatment. So just to reiterate, the only issue here is making sure that that assessment piece, the assess part, is performed with the opt-out model approach in mind. So again, we're not assessing whether or not the tobacco user wants to quit. No, we're assessing the level of their dependence and gathering other details about their dependence so that we can assist them more effectively. For instance, this information might help an organization to determine the appropriate level and type of medication or counseling that the person should be referred to. Again, the opt-out model has the ability to connect people to evidence-based tobacco cessation medications. And these are medications that have been proven to be effective and very safe. The 7 FDA-approved medications for smoking cessation are listed here. These all have substantial evidence behind them from an efficacy standpoint, and they're also extremely safe. And with the opt-out model, we're able to get a lot more people to use these medications. And if you recall on our slide back, we see a higher level of successful quit attempts when medications are present, even if counseling is not present alongside them. Okay, before we conclude the webinar, let's examine some of the interesting research that has been performed on the opt-out model for tobacco cessation in recent years. As you will see, more and more studies are pointing to the usefulness of the model, and specifically its ability to lead more people to tobacco treatment services and ultimately better health outcomes. Okay, so I've pulled a selection of particularly relevant articles and research studies on the opt-out model, and let's review some of these. We'll begin with the Richter 2023 article, very recent, just released. The key finding here was that opt-out care doubled treatment engagement and increased quit attempts, which we know is very important, in a randomized clinical trial, so a well-designed trial. We saw it increased the patient's sense of alliance with their practitioner. So they felt that they were operating with their, alongside that practitioner's advice. In this study, we saw that a total of 1,000 adults were treated at a hospital in Kansas City. So again, the patients were randomized into either an opt-out or an opt-in care group. They were assigned over a 4-year period. Follow-up occurred in March 2021. Interventions were provided to all the different participants, regardless of group. So at bedside, counselors screened clients first for eligibility. They then conducted a baseline assessment for those for which it was appropriate, and then randomized patients into one of the 2 study groups, again, either the opt-out or the opt-in group. Cessation services were offered to all of the participants, regardless of group, and those included counseling calls and medication. Patients could opt out of any or all elements of the care if they so choose. And for opt-in patients willing to quit were offered each element of treatment described previously. The opt-in patients who were unwilling to quit also could receive motivational counseling. And so verified quit rates for the opt-out group versus the opt-in group were 22% versus 16% respectively at the 1-month benchmark. It did reduce to 19 versus 18% at 6 months, but still better quit rates in the opt-out group. So the quit rates, again, in the opt-out group were uniformly higher in this study. Treatment use for the opt-out group versus the opt-in group showed an even greater discrepancy, where 60% of people in the opt-out group versus 34% received or were willing to receive cessation medication. And 89% from the opt-out group versus 37% were willing to complete at least one post-discharge counseling call. Excuse me. So we saw for both medication and counseling, the researchers found that the utilization was much better among the opt-out group. And finally, the opt-out care resulted in cost per quit similar to other cessation interventions, and of course, vastly lower than cancer treatments, for example. Okay, the second study there, Nahas et al. From 2016. This was an inpatient cessation service offered with an opt-out approach. Was found to positively impact short-term cessation outcomes. And it was an automated large-scale opt-out service for hospitalized patients. So the second study looked to evaluate the feasibility of implementing, again, a hospital-based opt-out tobacco cessation service, and found that an inpatient smoking cessation service with that approach could positively impact short-term cessation outcomes. It was a novel opt-out approach in that patients were eligible for cessation counseling support during and after hospitalization, regardless of whether or not they were ready to quit. In their findings, the researchers demonstrated that the feasibility of implementing the automated large-scale opt-out tobacco cessation service for the hospitalized patients could be done consistent with the recommended standards for treating tobacco dependence. They also found that receiving that bedside tobacco cessation consult with hospitalized patients increased the use of cessation medications and abstinence from smoking after discharge from the hospital. And even in those patients who did not receive a bedside consult, 5% accept a referral to the South Carolina Tobacco Quit Line to get help to quit smoking. So they were able to access another avenue to support their cessation, even outside of the study. So in summary, this study demonstrated that an automated large-scale opt-out service for hospitalized patients is in fact feasible, and moreover, may be highly effective in helping people to quit tobacco use. Okay, another study here, this one from 2021, Himmelfarb-Lith, Vanderwater, and Hartwig. These researchers found that the opt-out approach was more successful at connecting patients to cessation supports to optimize their cancer care. And as you can see there, increase the acceptance of quit support by about 3-fold. So the study looked at implementing a 3A's approach, so a modified version of that 5A's model that I looked at, and an opt-out tobacco cessation framework in an outpatient oncology setting. The researchers compared data from 2017 to 18, which was collected prior to the implementation of the opt-out model, and compared it against data from 2018 to 19, once the opt-out model had been implemented. And in that research, they demonstrated an increase in the number of patients screened for tobacco use, which bumped from about 77% to 90%, and in the number of accepted referrals to quit support, as we've already seen on the slide here. Therefore, the revised framework was effective at improving referral acceptance rates, even despite tobacco use rates remaining stable among the two groups, meaning those that received opt-out versus opt-in care. So this study demonstrated that employing the opt-out approach is a more effective strategy to connect patients with smoking cessation supports required to optimize their care. The second research here by Richter and Ellerbeck from 2014, a different type of study in which the authors evaluated the evidence base for opt-out care versus opt-in care. So a little bit older, but really helped to generate more interest in this. They did find that all tobacco users should be offered evidence-based care without being screened for readiness as a precondition for receiving treatment. So in other words, utilizing opt-out model. They also found it was more ethical. The researchers pointed out in this study that most health conditions, like we've talked about, diabetes, hypertension, asthma, et cetera, even substance abuse, the treatment guidelines direct healthcare providers to identify the health condition and promptly initiate evidence-based treatment. That's the standard across the healthcare industry. As with any medical care, patients are always free to decline. They can opt out from care. However, if the patients do nothing, they will receive that care. And so for tobacco users, however, they did point out that this treatment default was often been the opt-in model. They went on to point out that the approach has drastically limited the reach of tobacco treatment because at any given encounter, a minority of tobacco users will actually say that they are ready to quit, and as a result, few are actually offered treatment. So on the other hand, the opt-out care model for tobacco dependence is warranted because changing defaults has been shown to change choices and outcomes for numerous health behaviors, and because we know most tobacco users do want to quit, as we have seen. And interestingly, the researchers found little to no evidence supporting the utility of assessing readiness to quit as a standalone approach, and an opt-out default model is more ethical. Again, we should be assessing their dependence to gather useful information for their treatment, not assessing to decide whether or not they should be referred to treatment. So in the end, the researchers concluded that all tobacco users should be offered evidence-based care without being screened for readiness as a precondition for receiving treatment. Rather, they should automatically be referred via an opt-out model. Some good news is that the opt-out approach is receiving more and more attention across the country, and further research on this topic is being performed presently. Some of the organizations listed here, such as the Medical University of South Carolina, have participated in a previously described study, while some are currently carrying out studies. For instance, the Mayo Clinic has implemented an opt-out approach, opt-out referral approach at 33 different clinics and counting across the country, and is leading research into this practice and generating a lot of positive results in their research. Another study of interest, the Veterans Affairs Office, the VA New York Harbor Healthcare System, is currently enrolling patients in a well-designed cluster randomized design trial in order to directly compare which mode of referral is more effective, namely either the opt-out or opt-in approach. At the conclusion of this project, the researchers expect to have developed and tested an opt-out model for increasing tobacco cessation treatment for veterans in the VA primary care system. And they also expect to have a thorough understanding of factors associated with the implementation of the model, including an evaluation of whether or not an opt-out approach is cost-effective at the health system level. So in closing this webinar, I ask that you consider evaluating your own organization's workflow to determine if the opt-out model is currently being utilized in your practice. So some of the questions to ask yourself as guidance might first be, are all clients screened for nicotine tobacco use? Hopefully that is the case regardless of what model you're using following that. We know that that's an important thing to do at each patient encounter. The second question really is the key one for whether or not the opt-out model is in place. That is, obviously, are clients automatically referred to cessation services? This is really the key question to determine whether or not the opt-out model is in practice at your setting. and perhaps to identify what intensity is in place at your setting. Another question to ask is, are evidence-based cessation services being provided? So hopefully the answer here, if it's feasible in your setting, is yes, that evidence-based services are offered regardless, again, of whether the client must opt in or must opt out of receiving those. If you determine that you're not utilizing an opt-out model, or if you're interested in doing so, or learning more about other types of tobacco policies and procedures and techniques that you might be able to implement in your organization, I encourage you to consider rolling in next year's Tobacco Innovative Grant Project. We do currently have openings for the 2024 state fiscal year iteration of the project, which will begin on July 1st. Again, through the Tobacco Innovative Grant, we not only are able to offer these webinars, but we're able to offer free training around tobacco treatment, such as tobacco treatment specialist training and how to run a tobacco-free group. We're able to offer those trainings for free to sites. And we're also able to provide personalized technical assistance to sites around goals that they identify with regard to implementing tobacco treatment services and/or policies. And with that, we've reached the question and answer portion of the webinar. If anyone has a question, I encourage you to unmute yourself and ask it. You may also use the chat box if you prefer. And we have a few minutes left, so please let me know if you have any questions. And I'll just
This
pause.
is Casey Pierce with the Weld County Department of Public Health, and I'm in the tobacco program here. Something that we've been talking about is the opt-out model. Specifically when we work with clinics and trying to get clinics throughout our county to increase cessation referral resources and things like that. Our thing is I guess, how have you seen people actually get into clinics and have those conversations? I mean, I think from what I was understanding throughout the presentation is like, this is mostly for those of us who are already doing this, like maybe our internal clinic or things like that. But having conversations with clinics about even talking about tobacco can be difficult, like getting in there to talk about that. But having those conversations to suggest opt out, I think would be even harder for us. So I'm wondering if you've seen people who do that, or what that looks like. I don't know if that makes sense. I know that was a lot.
Thank you for your question, Casey. I'll see if I can offer some thoughts there. So I haven't seen research specific to how to have sort of unconventional or off-the-cuff opt-out conversations in those types of settings. Generally, what we recommend is trying to reach, with respect to tobacco use, trying to reach people where they're at in whatever context in which they associate with the greater healthcare system. And when I say the greater healthcare system, I mean all different types of healthcare systems. So with the Innovative Grant Project in mind, it could be homeless shelters or substance use treatment facilities, opioid treatment centers, for example. The key here would be that if we're at a point where we're doing tobacco work, and hopefully we are, we're doing it in the opt-out manner with that spirit in mind, that heart set, if you will. So when we're talking about the clients, or when we're talking with the clients, excuse me, we're assuming that they're going to take the next step in tobacco treatment. We're not asking them whether or not they're interested. Whatever ability we have to talk to them, we're operating from that standpoint that, okay, you're a tobacco user, here's the referral that I can offer you. So perhaps it's the quit line, the 1-800-QUIT-NOW number for the Colorado State Quit line, where they could get free medication counseling services. So if we have that conversation, it might look a little bit like, as opposed to saying, well, here's the quit line, you can call them if you're interested in learning more. And just that simple conversation, we just kind of change that script a little bit, where it's, here's the number for the quit line, call them today and they'll help you get set up with counseling medications so that you can quit tobacco, and the best thing you can do for your health. So I
get that piece, and I understand that, but don't know that it's answering my question in regards to when we're having conversations with clinicians. So like, I am not a clinician. I am a tobacco educator and like prevention specialist. And so we are trying to work with clinics to use those models, to refer to cessation efforts, to do those things and to have those opt out. And we want them to have that opt out as part of their everyday thing. And we want to have those conversations with the clinicians, and we're just not sure how to do that, how to facilitate that conversation. If I don't know if that makes sense.
Okay, I see. So how to train clinicians to use the opt-out model?
Well, train them, but also even to start the conversation about it. You know, I think something that we have found difficult is that, you know, like our Weld County Health Department's clinic, they ask every time if someone uses tobacco. So having that conversation with our clinician in-house and saying, hey, we'd really like to talk about opt out and what we can do to do that. I mean, that would be easy. But for the clinicians that are like through clinics throughout our county, that would be where we don't even know how to start the conversation with them, because getting in there to even have them ask about tobacco has been difficult. And so I think I'm wondering how we talk with them about even considering the opt out model, if that makes sense.
I think generally speaking, and I'm sorry if this doesn't answer your question directly, but I think the message that people need to hear, if they're, you know, we get it that people are very busy and they have a limited capacity to help people. The key is that we need people to understand the significance of the burden of tobacco. You know, too often we're worried about what's in front of us. You know, rightly so. We're worried about a specific condition. And ultimately, it's tobacco that is killing a lot of people, particularly behavioral health populations, as we discussed. I think it's that sort of message that needs to reach people, where the work that you're doing may not, you know, it may not pay off if that person's ultimately dying from tobacco. And I'd be happy to talk about this in more detail and try to get a clear understanding of your scenario if you'd like.
Yeah, sure. That's fine. I don't want to take up any more time. I know that we're at the end of things, and so in case anyone else has questions.
Well, I appreciate your questions and your interest in this topic. Let me, on the next slide, I have our organizational email there. I have access to that along with other members of our team. So please feel free to email us there, and we can set up a phone call and talk further. Any other questions about the opt-out model? I'll check the chat box, nothing there.
Kind of going off of what Casey was saying, I see that you are recording this. Is this available for review later? Maybe this is something that Casey or people like us who are tobacco educators or looking to become them can share with clinicians and the people that we would be working with, so that they can understand the opt-out model. It's a good like conversation starter.
Yes, I'm very glad you brought that up. And yes, I am recording this webinar. And yes, we will be getting it up on our website. You can see our website there, bhwellness.org. We'll have it on our Whole Health Innovation tab there, where we have past webinars as well. So I can reach out to you. I have everyone's contact information since you registered for this webinar. So I'd be happy to send that out when we get it up on our website. Fairly soon, not immediately, but we'll have it up there before long. Thanks for bringing that up, Angela. Last call for any other questions. Okay, thank you all. I'd be happy to have further conversations if anything comes up later. Thanks, everyone.